Hi, I'm Steve Selling, founder of FitTest, and in part one of my series on permanent pacemakers and implantable cardiac defibrillators, in this short video, I'm just going to talk about the basics of permanent pacemakers directed for exercise professionals who may deal with clients who have pacemakers. So permanent pacemakers, or PPM, are implanted for the following main indications: to treat Brady arrhythmias and cardiac standstill asystole, and I'll show you a little bit more on the next slide. But Brady arrhythmia is just referring to very slow heart rates, usually dropping even below 20 beats per minute. But even below 40 beats per minute, there's certainly alarm bells for most clients at those low levels. And that is probably the main indication for fitting a permanent pacemaker. To recapture the rhythm for the heart, for some tachyarrhythmias and tachycardias, modern pacemakers are very good at doing this. So they'll inject a pacing stimulus at just the right time to try and recapture the rhythm of the heart when some of these arrhythmias are occurring. Importantly, in heart failure management, pacemakers are often fitted, and this is a 3-lead pacemaker that stimulates both the left ventricle and the right ventricle and the left ventricle together to get that resynchronization of both ventricles contracting at once, and that will improve outcomes and function and quality of life and symptoms for individuals with severe heart failure. And this technique is also used, this form of pacemaker, also used for some patients with serious conduction defects. And from the exercise professional's point of view, we want those clients who have pacemakers to have an increase in heart rate in response to exercise. And this graph here, or this green graph here, is the heart rate response for someone with a permanent pacemaker who did one of my exercise tests, one of my clients. And this exercise, this is a sign and symptom and fatigue limited incremental exercise test up to peak exercise capacity here, and then into recovery. And you'll notice the first thing is we get this characteristic flat line of heart rate. So in other words, the heart rate locks into a certain constant level when someone is being paced at rest. And we get this nice anticipatory rise with the first minute or two of exercise, and then it joins a fairly linear increase in heart rate over the increases in exercise intensity. So this is a textbook, well-performing pacemaker for the sort of incremental exercise test that I do on all of my clients. Now, the next one is just showing another client with a pacemaker where there was some over-triggering of that pacemaker. So it over-triggered early in exercise and also in recovery. However, the rest of the heart rate response looks fairly normal, fairly much like the other client. Now, when I find this, I write this up, and then that goes into the pool of information for when someone goes back to the pacemaker clinic, and sometimes these settings are changed. I'm not saying necessarily based on the exercise test, but I have sequential data in some of my cases where these over-triggering events are improved with time. So just to take us through Brady arrhythmias and cardiac standstill asystole a little more. So asystole, as the term suggests, is just a lack of systole. So the ECG just flatlines, which is not a very pleasant thing for anybody, especially the client, but also the exercise professional looking after that client. So what you will see with a heart rate monitor is just a dramatic decrease in heart rate, either instantaneously or over a few seconds. And this absolutely needs to be reported on if you find it in and around exercise. Usually this will be a resting event. These days, there are implantable event recorders that can record these things and then remotely telemetrize the signal in real time back to a base station where there's 24/7 monitoring. And that person would then likely to get a call. For example, someone may be asleep when they go into asystole, and they may get a call in the middle of the night to say, you need to get into hospital, we're sending an ambulance and we're going to pick you up and bring you in. And I've actually got clients in this situation where the implantable event recorders either save their life or get very, very close to that. And those clients had a permanent pacemaker fitted within an hour or two of the asystole event. And similarly for sinoatrial node disease, the sinoatrial node being in the upper right atrium, and we can have what's called sick sinus syndrome, where we just get very long periods between successive P waves. In this case, the atrioventricular node is working fine because each P wave is followed by an R wave of ventricular response. So the problem is not in the AV node, the problem is in the SA node, and it's just simply not generating enough action potentials. And this is a heart rate well below 30. Sinus arrest is another form of this, a less serious form, where the sinus node just stops again, some flat line for a period, and then it comes back in. So that's all about the sinus node, and a lot of asystole is about the sinus node as well. And then we get down to the atrioventricular node here in the lower left of the right atrium, and here we have examples of high degree AV nodal blocks, and these usually need to be treated, especially third degree, but also some of the forms, one of the forms of second degree, where there's dropout of ventricular response with very low heart rates. Both of these need to be treated with permanent pacemakers. And then we get down to the left bundle branch and some of the conduction defects in the ventricle themselves. And there are other conduction defects which would lead to the indication or the need for permanent pacemaker. I've just given you one example here with left bundle branch block, but there can be bifascicular blocks as well, where both of these fascicles here block, and that can be create a real problem for conduction into the ventricles, pacemaker needed. Now we come to the forms of pacemaker. Now, first of all, single channel pacemakers. Now, I would say that it's a long, long time since I've had a client with a single chamber pacing, where the pacing wire is solely in the right ventricle and nowhere else. So there's no atrial sensing or pacing at all. This would be very unusual these days, and I simply don't see them. I'm just putting it up there to show you. So there's no pacing in the atria at all. And the pacing is down here in the right ventricle. The indications for single chamber pacemakers are sick sinus syndrome. So this is just to take over or make sure the ventricle is paced in the setting of very poor activity of the sinoatrial node, high degree AV nodal blocks, bundle branch blocks, especially bifascicular blocks. These are the things I just talked about on the previous slide. And also to inject pacing energy to intervene in the case of tachycardias and tachyarrhythmias. Now, all of these are important, obviously, but I don't think single chamber pacemakers are in any sort of common use these days to treat these. So we now go on to dual chamber, and this is much more the common situation for the same indications, exactly the same list of indications. I won't go over them again. And this time now we have right atrial, a lead in the right atrium for both sensing and pacing. So we have two leads, both sensing and pacing. And now we come on to a different form of pacemaker, which is called biventricular pacemakers. And these have three wires. So they have the atrial lead, pacing and sensing, the right ventricular pacing and sensing, but now they have a left ventricular lead as well for pacing and sensing. And this lead is passed through the coronary sinus, which allows access, probably the most simple for these highly skilled cardiologists, simple to access into the left ventricle via the coronary sinus system, the venous system of the heart. And these left ventricular leads are positioned in towards the left free wall. So they're not in the septal area, as is the right ventricle. They're over on the left free wall. And what happens is when the two ventricular leads pace, they pace together, and we get a few things happening. We get much more natural or native contraction of both ventricles, much more like real life ventricles contracting together. and that includes the outer wall of the left ventricle, importantly, the right ventricle catering for the right ventricular free wall and the septum mainly. And the other thing that happens on ECG is we get a narrowing of the QRS, which is a really strong indicator that both ventricles are contracting together. So that narrowing of the QRS, in fact, it's one of the criteria for doing CRT. This technique is called cardiac resynchronization therapy. The indications are left ventricular ejection fraction less than 35%, which is heart failure, a QRS duration or an R-wave duration more than 120 milliseconds, and New York Heart Association functional class 3 or class 4 while that patient is on optimal medical therapy and is not going to get any better with medicines. And so they then pace them by ventricular pacing. And also hypertrophic cardiomyopathy or HCM, and also HOCM, which is hypertrophic obstructive cardiomyopathy. A lot of those patients have this form of pacing as well. And then in the modern times, wireless pacing is coming in. To be honest, I don't have a single client who has a wireless pacemaker. There's the wireless probe here, which has been floated into the similar spot to the left ventricular lead that I showed you on the previous slide. This is floated in again using the coronary sinus access, catheter access into the area of left ventricular free wall. And this will sense what is going on in the rest of the pacing system, and then it will then run its own activity based on that sensing that is going on, say, in the right ventricular lead. So we still have the right ventricular lead, the right atrial lead, but also this wireless lead here in the left ventricle. Now, how are pacemakers implanted with the endocardial approach? The endocardial is inside the heart, so it's a catheter approach via a venous access into the right ventricle. In this case, I'm just showing a single lead access on this diagram, but it's the same for 2 or 3 leads, exactly the same technique. Now, because these pacing wires are deep inside the heart, you can't actually see on ECG the pacing spikes. So if you know someone is being paced and you can't see the pacing spikes, it's usually because they've had a transvenous catheter implantation, also known as endocardial. And then epicardial, which is done during open heart surgery, so it could be done during CABG or coronary artery bypass graft or valve replacement. And here the pacing wire sits outside the heart, and it's not, it certainly can be done during open heart surgery, but in my experience, these pacemakers haven't got as much power, as much sensitivity on the pacing parameters and the ability to program, fine-tuning the program. And so I would think, without knowing for sure, that most cardiologists would prefer to have the pacemakers implanted using the transvenous or endocardial approach. Now we come now to pacing protocols, and this does get a little bit tricky with the terminology and also what all of these very complex pacemakers are doing. Now, first of all, the terminology is the first letter in the pacing protocol is to do with pacing. The second letter in the pacing protocol is sensing. And the third, so you sense before you pace, even though it comes after in the acronym. And then the third part of the acronym is either inhibiting or triggering. These are inhibiting or triggering pacing energy. And the last one with a hyphen in between is rate responsive. And this is the one which comes into play during exercise, the R. So I'm not going to skip through the very old examples of this. You can stop the presentation here and have a read of those if you like. I'm really not going to talk about them at all. The V just stands for ventricular pacing. Here in VVI, it's ventricular sensing, ventricular pacing, and inhibition only, but no atrial control at all. And this one is atrial sensing with ventricular pacing and just triggering on atrial sensing. I'm not going to talk about those anymore. We now come to the modern versions, and this is the first ones is atrial sensing and atrial pacing with inhibition. So it will inhibit atrial pacing if it senses that there's a faster intrinsic atrial rate, and it's also rate responsive for exercise. So if the atrial sensing senses that there's native faster intrinsic atrial rate coming through, it won't pace. It will allow that so-called sinus or even atrial rhythm to pace the rest of the heart, including the ventricles. This does assume that there's not too much or not high degree AV nodal block to be able to do this. Otherwise, it couldn't be done. It's useful in the slower bradyarrhythmias, but it's not useful in atrial fibrillation or atrial flutter, as you can imagine, or supraventricular tachycardia, because here we have very fast atrial rate, and it will then inhibit the pacing, and that will then allow the ventricles to over-respond and have very high ventricular rates. So to deal with that, we have another type of pacemaker, DDD, which stands for double sensing. Which double means ventricular and atrial. So atrial and ventricular sensing, atrial and ventricular pacing, and both inhibition and triggering events are allowed, and it's also rate responsive for exercise. This is very much a modern pacemaker. It's used in dual chamber pacing and sensing with both inhibition and triggering of atrial and ventricular pacing according to what is going on intrinsically. In other words, what is going on with the sinus node and the AV node and the conducting system in the heart. So it looks at all of those. It's rate responsive, so it's good in exercise. It can switch from the double chamber pacing, sensing and pacing to triggering events, but also can also be used to inhibit events. So it's useful in atrial fibrillation. When the atrial rate is very high, the pacemaker will switch to an inhibiting form so that it won't pay, so it will allow us a lower heart rate on the ventricles so that the ventricle does not follow the atria with a very high rate. So there's a tremendous amount of clever computing and engineering in these pacemakers, and I will have more to say about them in one of the case studies in part 3 of this video series. So coming now to just a little bit on the client that I'm going to talk about in part 3 of this video series, just on the topic of AAI responsive and DDD responsive pacemaker. This client actually has a dual mode pacemaker that can switch between the atrial dependent pacemaker mode and the dual mode here. So in the atrial dependent mode, where there is atrial chamber pacing and sensing, here the pacing spike was put in. Incidentally, you wouldn't see that. Pacing spike's been put in here because it didn't get a P wave, didn't happen. So this would be, say, on standstill. It's put in a pacing spike for the P wave, and then the ventricle is followed. So there's no ventricular pacing here at all. The ventricle is followed because the AV node is intact, and you've got normal conduction from after the pacing spike. And then the other option is to sense that there is a P wave there, a native P wave, and there is a native QRS. And so this is effectively just a sinus beat with the pacemaker sitting silently in the background. Now the DDDR method, there's now 4 options here. We've got the sinus beat option, part B here in this diagram. We've got part C, looks very much like the AAI option, where it sensed that it needed to put in an atrial spike, so we get an atrial contraction, but the ventricles followed nicely. In this option here, there was a native atrial spike, or atrial contraction, atrial activation, but it waited and then it put in a ventricular spike because there was none coming. So that was built into the programming. And in part A, which is all of this combined, where there's both atrial pacing and ventricular pacing. And in these ones here, there will undoubtedly be inhibition of ventricular pacing because it wasn't needed. These were using the normal AV node and conducting system. So that's all I wanted to say about the very basics of pacemakers, how they're fitted and what sort of things they can do. and their main medical indications, and just introducing a little bit about exercise. So if you're interested in, if you need to follow up, you can contact me at info@myfittest.com.au. So have a great day and bye for now.